and welcome to Duke Spine Institute live stream spine surgery. It is February 13, 2025, just before Valentine's Day. Our patient is from Florida. He's having chronic back pain. 2 discs are damaged. You can see it on the MRI on the bottom right. He has degenerative disc disease, spondylosis, spondylolisthesis, degenerative scoliosis, pars defect. He does not want fusion surgery, so we're going to try to fix his back without it. I expect to be able to. I give it about a 95% chance of success, getting rid of his pain in his back and legs without having to do any kind of fusion surgery. He wants to avoid fusion. He's an athlete, but he does have spondylolisthesis and a pars defect, so we have to keep that in mind. I've treated many patients with laser over the years with exactly this problem, and I have not had to do fusion on any of them. If you talk to spine surgeons from around the world, half of them say with spondylolisthesis you need to do a fusion. The other half say you don't. So there's sort of a mix of opinion. In my opinion, if I'm doing a laminectomy, then I need to do a fusion if they have a spondylolisthesis. On the other hand, if we're not doing laminectomy, then we don't need to do fusion. Sean? All right, so I'm going to work on getting down to the 5-1 disc. Very difficult, but we're going to give it our best, and I expect to be able to get there. Sean? Sean? In the meantime, Henry, if you want to show our audience, why is it that herniated discs cause so much pain, then our audience could understand better.
Of course.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
I'm going to need him awake. Shot. Let me know when you've got him. Let's go ahead and get the needle on the other side.
Okay. I'm going to ask you some questions. Open your eyes for me. That's good. Open your eyes. Good. We're going to ask you some questions, okay? You're doing great.
Shot. Huh? All right. Shot. 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 AP.
Questions, just stay with us. Doing great. Doing really well.
See if he has any pain.
Are you having any back pain right now? Not right now.
Any pain at all?
Any pain at all? No.
We have a question.
I'll take it in a moment, not right now.
Not a problem.
Shot? Any pain? Huh?
What's that? No. You just say yes or no. It's easier. You have an answer.
Any pain?
No.
Sean? Where do you feel it?
Lower right side button. Travel into your legs?
Not in your leg.
No.
Wonderful. Any pain? Where?
Where is it? Lower left side going into your leg? No.
Sean? Sean? In the back? You just the back, not down your leg. Well, I don't know how we did it, but we got lucky. Right, Luis? Better be lucky than good. So we've already numbed up his skin a bit. Now we're gonna place our, everyone agree, right 4-5, right 4-5, yes? Sean? Okay, Sean? Feel it in your back? All right, that's okay, that's normal, Sean. You're doing great, everything's okay. Sean, he's very thin. His spine is quite posterior. Sean? Where do you feel it?
Lower right side.
Sean? All right. But not down your leg. Sean?
Where do you feel?
Where? Lower back? Okay, not down his leg. That's important. All right, are you comfortable? How long have you had back pain for? How long? 15? All right. Are you having it right now? No? How did you find Duke Spine Institute? Your friend?
Yeah.
All right. Well, we've got two discs. We have L5-S1 that we believe is causing pain and L4-5. Are you having any pain right now?
Yeah.
How bad is that on a scale of 1 to 10?
9.
The highest it went.
9.
Is that where you get your back pain? So we got 9 out of 10 concordant L4-5. Is it better now? Sorry about that. We were testing to make sure we're in the right spot. All right. Is it better now? Henry, did you hear him?
A little bit, yeah.
Yeah, when he said, ah.
Yeah, we definitely heard that.
Are you better? How bad is that on a scale of 1 to 10? 10? All right. Is that where you typically get your back pain? That's L5-S1 is 10 out of 10, and it's concordant. Good news, when you wake up, that pain will be gone for the rest of your life. So, folks, great news. I want you to count from 1 to 100 out loud in Spanish. All right? Count. If you don't know how to speak in Spanish, count in Greek. Just kidding. Count out loud from 1 to 100 in English then. So our patient has had back pain for 15 years. He's an athlete. He's got a listhesis, stenosis, spondylolisthesis, all this. He's even got a bifid spine. We didn't see a spinous process well developed or connected in the midline at L5. So he's got all this back pain coming from the discs. We're going to go in there and repair these discs. Now there's other causes of back pain besides the disc. The disc represents about 90% of chronic back pain, 85, 90%. but there's other causes. Henry, let's show the audience, while we're getting the surgery started, the 30 different causes of back pain.
Of course.
I'm Dr. R. Duke-Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke-Majan. Thanks for joining us. And welcome back. You can see from our video there's many causes of lower back pain, but we know them all and they're very specific. Once we identify the cause that a patient has, then we know the exact treatment they need to get rid of it. And fortunately, we have cures for each of those 30 causes. This patient, his pain is coming from 2 damaged discs at the bottom of his spine, L4-5, L5-S1. The discs are severely damaged, degenerated, collapsed. Even one of them is slipping. The bone is slipping on each other, called spondylolisthesis. Spondylo means spine. Listhesis means to slip in Latin. So it's a slipping spine. We talked about it, and I told him, listen, you know, the jury's out. Many people say you don't need fusion. Others say you do. In my opinion, based on many years of doing these surgeries, I would say as long as we're not removing bones and ligaments from your spine at L5-S1, you don't need to worry about fusing L5-S1 because you're not going to create instability with the surgery, and the spine is stable enough, it'll be fine. It doesn't get worse. So we got lucky. I was able to get into the L5-S1 disc on both sides. Honestly, don't know how I do it sometimes. I think it's God's will. Obviously, I don't know how I get into some of these discs, honestly. It seems superhuman to be able to get in. There's really no space to move the needle through. And we were just very fortunate in him to get into 5-1. He was awake. He helped guide me. And Dr. Berndes did an amazing job with the anesthesia. My team did an amazing job with positioning. But I know I make this stuff look easy for you guys. This part right here is easy. The laser part is easy. The hardest part of this surgery is to get the needle threaded through a tiny, tiny little hole at L5-S1 that's there, because you're literally threading a needle without even seeing the needle. You can only use the x-ray machine to guide. And so we got lucky, we got in, and right now we're fixing L4-5, but we're going to be fixing L5-S1 next. Okay, so I understand we have a few questions. I'll take those questions while we're working here with the laser to clean out this tear at L4-5.
First question coming from Faisal on Facebook.
Hello, Faisal.
Asking Doctor, C5 through 6 disc replacement surgery I had in September of 2022, 2 months after my right arm pain returned. I found out from a surgeon that did not remove the bone spur on the right side nerve root properly, hence why the pain returned. After the pain came back around 2 months after, he said that I should get physio and chiropractic treatment and did not want to know me and discharge me from his clinic. 2 years I've been suffering with neck and arm pain. What would you do? Complain? Sue? Thank you.
I know what I would do for sure. I would contact Dr. Duke Majan at Duke Spine. I would get his opinion on what needs to be done to fix my problem, and then I would do whatever he told me to do, and I would do it and get it done right away. That's what I would do.
Next question coming from Jacobo45.
And I want to say one thing,
Yes.
Faisal. Your right arm symptoms may not be coming from C5-6. That's why you need me to help you figure out where they are coming from. Go ahead.
Next question from Jacobo45 on YouTube. Asking, hi doctor, what are you offering us, mere mortals? Is it uniquely generous and informative? Thank you for that. How can you differentiate between the pain caused by piriformis to that caused by herniated discs?
That's a great question. The answer is location, location, location. And the piriformis is located in the top of the buttock. So if the pain is in the top of the buttock and it's tender when you push with your fingers, then it must be piriformis. Disc pain never is tender. When you have a disc causing the pain and you push on the buttock, there is no tenderness. Zero, zippo, nada, nothing. That is the key. So the diagnosis is a clinical diagnosis for piriformis syndrome. And I've just treated so many. There's nothing else there that causes pain and tenderness in the top of the buttock. Now in the bottom of the buttock, there is something called ischial tuberosity tendonitis, which is basically inflammation of the hamstring attachment to the skeleton, to your ischial bone, your ischial tuberosity. All right? So, top of the buttock, piriformis, bottom of the buttock, ischial tuberosity tendonitis. Ischial tuberosity tendonitis is treated with injections and therapy. The injection is done typically with an ultrasound guidance, and we inject a steroid medicine. Dr. Patel does that here, and Dr. Damola is learning how to do it. On the other hand, piriformis syndrome is really only fixable with surgery. I hope that helps.
Believe so. Next question coming from Smarzig on YouTube,
Hello, Smarzig. Welcome.
asking, after the piriformis muscle release, can people act and do normal range of motion?
Yes, there are no restrictions after the piriformis muscle release. None. You can do whatever you want to do. There's no limitations, no restrictions, and the piriformis muscle will actually heal relatively quickly in a couple of weeks, and it actually will preserve some of the function of the piriformis muscle too, which is very minimal to begin with. But all right, just about done here at L4-5.
We have a couple more questions. Next one is coming from Paul on Facebook,
Hi, Paul.
asking, Dr. Duke, after you remove the herniation from the disc,
I can't turn it.
what prevents the disc from continuing to leak out, and do you treat a bulging disc the same way you treat a herniation?
Well, great question, Paul. Take a look right here. You see this? That's the disc. Do you see it leaking? Nope, because it's not liquid, it's solid. So whoever told you it's liquid lied to you, which there's a lot of lying that happens in the world, misinformation. The disc is not liquid, it doesn't leak.
Next question coming from Smarzig once more on YouTube, asking, is it possible to have TORP here form as end disc herniations at the same time?
It is possible to have piriformis muscle and disc herniations at the same time. Absolutely, very common problem. We see that very commonly. Let's go ahead and show the audience, since there's so many questions about piriformis syndrome.
Yes.
Let's show them our animation on the piriformis muscle, how it hurts, and how we fix it.
Of course.
A piriformis muscle tear can cause lower back pain and sciatica. A piriformis muscle injury causes a tear, in which piriformis muscle inflammation causes back pain. And also, piriformis muscle inflammation may cause sciatic pain. The best treatment for piriformis muscle syndrome is the Duke piriformis release. From there, the piriformis pain is permanently eliminated. The advantages with the Duke piriformis release is that it's an outpatient procedure, which would take up to about 30 minutes, minimal bleeding and pain after the procedure with an immediate recovery and return to work the next day, as well as a 99% success rate with permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
Okay, welcome back. We are just about finished with L4-5 on the right side, and we're going to move on to the L5-S1. Next, I'm just grabbing out the last few pieces of herniation that are here in this tear. Any other questions?
Yes, we have a question coming from John on YouTube
Hi, John.
saying, do you guys take TRICARE or VA community care insurance?
We take both, but they won't pay for the laser surgery. Neither of them will. Remember, the government's not really interested in taking care of veterans or active military. They just want to look like they are, but when it comes to actually paying bills, they don't really pay the bills. So I'm sorry, but I'm happy to see you for free. I just can't perform surgery for free. Or we can do a free MRI review, give you a diagnosis. Maybe you can do something with that. We do get a lot of military that come here, but they do have to pay out of pocket a patient responsibility, unfortunately. Doesn't make me happy about it, but I can't pay for everybody's medical care myself. And that's what I would be doing if I relied on the VA and TRICARE to pay.
We have another question
Uh-huh.
coming from Professor on YouTube
Hello, Professor.
asking, does Duke Spine Institute accept workers' comp from New York City?
We do. We do accept workers' comp from New York City, but again, New York work comp stopped paying bills, and they're very difficult to get money from. So what we would have to do is we would have to work with your work comp insurance. As long as they're willing to pay for the surgery in advance, then you're good to go. If they're not, then you would have to pay, and then we would bill your insurance and be able to refund you your payment if they pay more than what you paid, basically. I know it's complicated, but insurance are very difficult to deal with. They have all kinds of schemes they use to not pay the bills. And in the end, if they're not paying, then we go out of business unless we get the money from the patient. Laser. So we do have to collect money from patients quite often when their insurance won't pay.
We have a couple more questions.
Sure.
Next one coming from Smarzig once more on YouTube
All right, Smarzik, hi.
saying, hi, last question. Sorry to be a pain.
You're not a pain, Smarzik. We love your questions, first of all.
Of course.
Second of all, every time you ask a question, you help other people who are not asking questions. There are a lot of people who just listen and they wait for people like you to ask questions to get answers. So I'm glad you're asking questions.
Exactly. Not a pain at all, Smartzig. But they did ask, did you watch or hear about any of the RFK Jr. hearings? He just got confirmed today, finally.
Wow. I have not really watched in detail, to be honest with you. I haven't had time. But yeah, I hope he's able to do some good for our country. You know, Trump believes in him. I don't know enough about what he's going to achieve, this guy, but hopefully, I know he seems motivated to do the right thing, but we'll see.
I agree with that. I watched a little bit here and there, and so I love Bobby. He's just a good guy, and so, but just politics aside, I really hope he does really well for in his position. So, next question coming from Paul on Facebook, asking once more on Facebook, asking, do you treat a disc bulge the same as a herniation?
Yes. A disc bulge is a herniation, Paul. There is no difference. A disc bulge is just a small herniation. Herniations can be any different size, from a bulge all the way up to a gigantic extrusion. So size does not matter. Size does not equal symptoms. A lot of people think bigger means more symptoms. That's not true. There are people with gigantic herniations and zero symptoms. We don't treat them. Nobody does. You leave those people alone. On the other hand, there are people with tiny bulges which are herniations that are small, and they have humongous symptoms, horrible pain in their back or neck, and we would treat that, yes. We don't treat the MRI, we treat the patient. That's a very important thing to understand. You treat the patient, not the imaging. The imaging can guide you, but it does not tell you if a patient needs treatment or not. The patient will tell you.
And at this moment, no current
Right.
questions.
I think we're done with this disc. Just a little bit of fat. Henry, we showed the piriformis.
We have shown the piriformis, correct? The 30 causes of back pain, how a disc causes back pain, and how we cure it. And yeah,
All
showed all
right,
those.
very good. We'll just carry on.
Yes, sir. If any questions come up, I'll let you know.
Thanks.
You get here?
Shot. Oh, guide wire is fine. Shot. 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 Wait. All right. Very difficult, yeah. But I think we're all right. Thank you, Luis. Shot. Keep an eye on that tip. Where's the tube, you think? All right, that's good. Let's bring it out slowly and just double check it. Getting over my pneumonia.
You got pneumonia?
Yeah.
You get that?
I had a viral sinopharyngo laryngo broncho pneumonitis. And then I developed a secondary bacterial infection. So, yeah. You know, every what, 6 months there's some virus goes around. Gets people. We've got a lot of people out. You know. All right, here we are at 5-1. You can see the blue nuclear material from the disc injury, from the degeneration. And we're going to try to remove as much of this as we can. Any questions?
At this moment, no current questions.
All right, just to reiterate, this patient, we tested these 2 discs to see if they were the source of his back pain, and they were. One was a 9 out of 10 concordant, the other one was 10 out of 10.
We just got a question
Sure.
coming from George on YouTube,
Hi, George. Welcome to our live stream, Spine Surgery at Duke Spine Institute.
asking the modern endoscopy techniques don't work in the disc. There are USA and Europe endoscopic surgeons. Can you comment on that, please?
Yeah. Yeah, I think you got to understand something. This is the best technique of all, but not everyone is able to do it. So the surgeons that do endoscopic spine surgery, like biportal technique, abbreviated UBE, they're actually destroying your spine to get to the disc herniation. They're doing a laminotomy, which they don't talk about. And they're really destroying your ligaments and bones, weakening your spine. This technique is the best of all, but it cannot be done by everybody. You have to be a very, very, very good surgeon, the best of the best in the world, to be able to do this technique. And that's why I do it, because it's the best for the patient, and I am a very good surgeon. So I have no problem getting it done. But the other techniques are worse. But they're easier for the surgeon. They're easier for the surgeon. So the surgeons do it because they can do the surgery. Otherwise, they wouldn't be able to do any endoscopic surgery. So we have to give them training wheels so they can get it done.
We have another question
Sure.
coming from John, once more on YouTube,
All right, John on YouTube, welcome.
asking, I know there is detailed screening before a patient is given the okay for surgery, but how would you handle a full arrest if you're working on the patient's back? Like, how do you perform CPR?
That's a great question. So this is true for any surgery on any patient around the world, right? Not just at Duke Spine Institute. But the arrest is picked up on usually by the anesthesiologist, and there's always signs that you can see it coming before it happens. It doesn't just happen on the drop of a hat. There's usually changes that occur that are visible on our monitors that we use. And when you start to see those changes, you start to prepare. You get medications ready. You tell the nurses in the room, get the crash cart. Basically, you prep, you prepare. You have a little bit of time, a few minutes maybe. And basically what we would have to do is we'd have to pull the tube out, which takes about a second. And then we'd have to staple the wound, which takes about 2 seconds, so that's 3 seconds. And then we would, by that time, have the gurney in, the fluoro out, and we would flip this patient on their back so we could code them. We already have IV access. We've all been trained. And the truth is, I would not be the one to run the code because I'm a neurosurgeon, and frankly, there's better people than me to run a code. So I would have our anesthesiologist, Dr. Berndes, running the code along with our charge nurse, and the other nurses would be supporting. We would have somebody documenting like they're supposed to. But basically, every surgery center and every hospital in America and the rest of the world is supposed to be ready to run a code on a patient who's having surgery. So we train for it, we prepare for it, and hope to God that we never have to do it. Great question.
And at this moment, no current questions.
All right, we are working on the herniation. This is it right here. Okay, I've been working on it. This is a different part of it. This is a old part, very scarred up. That's what this laser is hitting, this hard stuff. It's very firm. This is what was pinching his nerves, giving him weakness in his legs. You can see all the gold coloration, that's calcium. Should not be there, that's abnormal calcium. If it gets to be a lot, then we call it a bone spur. Just about done. 5 minutes on this disc, Dr. Berndes. This is so hard right here. This is the part that's out by the nerve too. The nerve is just outside that tube right there. To the right. Right where that piece of herniation just came out of. So this stuff is all pinching the nerve root, we call it. It's very hard stuff. It's like candle wax. It's probably the best way to think about it. Hard like candle wax, cold candle wax, not hot candle wax. Yes. Everything okay? All right, just trying to get this last bit here. We got one more to go. It's hard to see. Water is coming out the tip. Any other questions?
At this moment, no current questions.
All right. Once again, we're right side, L5-S1. We've already done L4-5. I'm trying to grab, with the grabber, any loose pieces that are easy to get. Unfortunately, most pieces of herniation are not loose. They're stuck down with scar tissue. The average disc herniation has about 30 to 35 pieces of herniation. Oh, look at all that, just pushing out hard into this tube. Candle gutterings. Anybody know what candle gutterings are?
I don't believe I've ever heard of that.
Well, when you light a candle and that wax drips down the side, it looks like little tears.
Yeah. Oh, that's what it's called?
That's a guttering.
Oh. No, I never knew the name of that. I didn't even know it had a name.
Yes. Look at that piece of herniation. You guys see that snowball that came up?
Yes, we did.
Hopefully it's up and out, but we'll see. All this is herniation here. Very scarred. All that white stuff is scar tissue around the herniation, encasing it like concrete. This is what bulges out backwards towards the nerve and pinches the nerves. This is what causes spinal stenosis. All this stuff here.
We have a question
Sure.
coming from Paul once more on Facebook, asking, is the patient under twilight or general anesthesia, and what are the criteria for each?
So this type of surgery we're doing, which is the lumbar Duke laser disc repair for a lumbar disc, is always twilight. we use propofol sedation. Now sometimes if the patient is a high risk, we'll do general, but for the most part it's just propofol. So this is IV sedation with injecting a medicine called propofol in the vein that knocks out the patient in the right dose. Monitored by the anesthesiologist. If you give too much, the patient will stop breathing. We don't want that because they're not intubated. We don't have a secure airway. So general anesthesia is when you have no reflexes, brainstem reflexes to protect your airway or your gag. You're so deep asleep that you have to have a tube down your throat to help you breathe, but also to block any secretions from getting into your lungs and causing a aspiration pneumonia because you're so deep. You can't protect your own airway. So you need the doctor to protect it for you. That's the difference. Twilight, you're just heavily asleep. General anesthesia, you're completely out and unprotected. You need us to do more for you. Am I missing anything, Bernadette?
General anesthesia, the anesthesiologist is breathing for you.
Yeah.
And with twilight, with sedation, the patient is spontaneous.
So general anesthesia, the anesthesiologist uses a machine to breathe for you to breathe and breathe for you. Whereas with twilight, the patient breathes themselves. They're just sleeping. All right, just about done. It's all herniation at L5-S1.
We have another question
Yep,
coming from Smarzig once more on YouTube,
Smarzig.
asking how long do the discs take to heal back to normal?
Yeah, great question. About a year, Smarzig, 12 months. Could be a little bit less, 9 months, but I tell everybody 12 months. That's the best information we have. Some people may take a little bit longer, but some people may be a little bit shorter, but that's about the average.
Dr. Duke,
Yeah.
maybe you can talk about a little bit people that are quite athletic, like going to return to like certain activities like riding.
Sure. Yeah, we get a lot of questions about levels of activity when you're done with surgery. You can actually go back to riding a bike 2 weeks after surgery as long as you're upright, not hunched over, no Tour de France stuff. And people can go back to golfing 2 weeks after surgery, playing their short game, no driving. I don't like driving for 3 months, generally. Driving the ball. You can drive a car the next day. I don't recommend driving a motorcycle though. You need to give your back time to heal. Motorcycle, I would wait probably 3 months.
What about swimming and tennis, racket?
Yeah, racket sports, you can start easy racket sports, usually within a few weeks. Swimming, just 3 days.
Swimming is 3 days.
You know,
I get that question a lot.
3 days. You want to let the skin epithelialize. It takes about 3 days. All right, just about done here.
We have another question coming from Smarzig once more on YouTube, asking follow-up, how do you know the discs are healed?
Well, we don't know for sure the discs are healed. We can only guesstimate, but there's no way to know anything's healed in the body, to be honest. Doesn't matter what surgery a doctor does. We have just estimates, basically, that we use. There's no way to test to see if it's healed.
It's a low blood supply tissue, right? So you have to heal it.
Yeah, the disc is a low blood supply tissue. Takes a long time. But it doesn't matter what you're talking about. Whether you're talking about a hernia repair, like how long does it take for the hernia to heal, right? After surgery, you don't know. You only have your best guess, an estimate, based on years of treating patients. But it doesn't mean that patient's going to be the same. So everybody's a little bit different. All right, I think we're done. Once again, we're not going to see a normal disc at the end of the surgery. We don't expect to. We expect to have a pain-free disc. That's our goal. Eliminate pain. Improve function. If you get rid of the patient's pain, then they can go back to doing normal things. Okay? People ask me, is this a stabilizing surgery? Yes, it is. The definition of instability is severe pain or neurological deficit with normal physiological loads. So if I get rid of his severe pain and his neurological deficit, then we've won. So we stabilized him. Any other questions?
At this moment, no current questions.
All right. We're going to go to the other side and finish up. $7 mm incision. Oh. All right. If you have questions, feel free to ask. Otherwise, Henry, why don't we show our video on how a disc injury causes so much pain?
Copy that. Oh, yep, copy that. Not a problem.
Disc injuries start with an annular tear. Damaged nucleus. Pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Take it out. Welcome back. We're inside the 5-1 disc on the left. We've just finished the right side. Now remember, since we just did the right side, the left side's going to have some blood. You're going to see because it carries from the other side. So it won't look exactly the same. That's good. If you have any questions, feel free to ask. All right, bring it out. Well, this is our last disc. We're almost done. After this, we have another patient in room 2.
Yes.
And then we'll be back for a thoracic patient with 2 discs. Thoracic from Miami. She has severe pain at her bra strap, where her bra strap is. She has 2 herniated discs. Huh? It's like T10, 11? All right. That's what I mean by the blood. Very common since we're seeing the blood from the other side. Is the scope on? All right, we're inside the disc and hopefully not have too much to do on this side. Any questions?
Yes, we have a question coming from Jacobo45 once more on YouTube.
Sure.
Asking, why do some surgeons use neuromonitoring?
Yeah, neuromonitoring is used for certain types of procedures. I use it as well, usually for fusion. If you're going to put in screws into the pedicles around the nerve roots, then you should use neuromonitoring. The reason is you want to see if you're damaging the nerve while you're putting in the screws. You can't see the screws in the bone, so all you can do is see where the screw enters the bone, but you can't see the full trajectory of the screw. So if the screw breaches outside the bone and it's pinching a nerve, then you wouldn't know. So that's why you use neuromonitoring. It can tell you that you've hit the nerve and breached the cortex of the bone when you're putting in hardware. The other time is when you're operating on the cervical spine or thoracic spine. You're worried about the spinal cord being damaged during surgery or being pressed on by the cage or screws. Then you can also do neuromonitoring. So basically it's to monitor the nervous system, to look for any changes in function of the spinal cord or nerve roots while you're operating in those areas. There's also other types of neuromonitoring done outside the spine for brain surgery. For example, we use neuromonitoring, taking out tumors, for example, that are near visual system or auditory system. So neuromonitoring is used to monitor nerves, to make sure the surgeon isn't damaging nerves while they're doing their surgery. All right, we've got 5 minutes, Dr. B, less than 5 minutes. We are ablating this abnormal tissue that's found in the tear. This is the source of the patient's pain. By removing this with the laser, it gets rid of his pain coming from the disc. Hopefully he doesn't have pain from anywhere else. Any other questions?
No current questions. Jacobo45 meant to re-ask, why do some surgeons use neuromonitoring during surgery and some do not? That was
just individual preference.
Other than that, no current questions.
That's all I can tell you. One minute. It's kind of like playing a video game, huh? You're actually not looking at your hands, you're looking up at the board. You know? This type of surgery is a lot like playing a video game.
No current question, but we do have a comment coming from Smarzig, once more on YouTube,
All right, Smazig.
saying, last comment, I have started saving up for these procedures and will soon upload my MRI to the portal. I have watched so many of these streams, I could probably work there now.
Well, come work. We have openings. We're always looking for enthusiastic, bright people who love to work and help others get better. You know, work in a medical practice. We're always looking for good people to join our team. So, all right, we are just about done. I'm just going to clean up this last bit of stuff. Unless I get surprised. Some of this is scar tissue right here.
We just have 2 questions. Next one coming from Professor, once more on YouTube,
Okay.
asking, how can you be sure that no nerve will be damaged during the surgery?
Well, first of all, I know where all the nerves are. And so, as a neurosurgeon, it's my job through my training to not damage nerves. So I can tell you, we don't damage the nerves. At least I don't. I can't say that for other neurosurgeons. So number 1, know where the nerves are. Number 2, protect them. See this tube, this metal tube? This metal tube is protecting the nerves. They're outside the tube. So the laser and my instruments cannot damage the nerves because they're outside the tube. One of the nerves is exactly over here and the other nerve is over there. So one is at 12 o'clock, one is at 9 o'clock. All right. $12 and 9 o'clock.
We have another question
Uh-huh.
from Paul, once more on Facebook, asking, is a second incision required for the plasma rhizotomy?
Yes, it is. Because the incision for the laser surgery on the disc is in a different place. And the plasma rhizotomy incision needs to be closer to the midline, closer to the medial over the facets. So they're 2 totally different places. I mean, they're separated by maybe an inch or 2, but... All right, thanks for joining us. We'll be back for one more thoracic surgery. We have another surgery to do in room 2, which we won't be broadcasting because we don't have a camera set up in there. But long story short, we'll be back shortly with our final surgery. I got it. You just do other stuff. So thanks for joining us.